They say the burn unit is where angels fear to tread. After 15 years working as a burn unit nurse, I can tell you that's absolutely true. I've seen things that have left permanent marks on my soul in ways I'll never recover from. The distinct odor of severe burns mixed with infection, it never leaves you. It stays with you long after your shift ends. Tonight, I'm going to share 15 stories from my time in the burn unit that still keep me awake at night. These aren't fictional tales or urban legends. These are real cases I witnessed firsthand. Before we begin, please hit that subscribe button and turn on notifications so you never miss our medical stories. Drop a like if you're ready to hear what really happens behind those burn unit doors. And comment below if you've ever worked in a burn unit yourself, because I know I'm not alone in these experiences. The first time I walked into a burn unit, I was a brand new nurse, fresh out of nursing school, full of hope and idealism. That lasted exactly 45 minutes. What you need to understand about burn patients is that their suffering is unlike anything else in medicine. A heart attack patient can be stabilized. A cancer patient can go into remission. But a severe burn patient, they face weeks, sometimes months, of unimaginable difficulty. Every breath causes discomfort. Every movement is challenging. And we nurses are the ones who have to perform painful procedures on them every single day, just to keep them alive. So let me take you into my world. A world of exposed tissue, of damaged skin that requires constant care, of sounds that echo in your mind forever, which was fortunate. I, however, had to witness everything. As I watched Sarah carefully protect that exposed bone with sterile materials, I felt my vision narrowing. The room started to spin. The next thing I knew, I was in the hallway with Sarah standing over me. "Happened to me too. First time," she said, helping me up. "But we don't have time for this. Michael needs us." I went back in. Michael survived for 17 days. Each day was extremely challenging with dressing changes, tissue removal, and watching him slowly decline despite everything we did. The infection spread despite powerful antibiotics. His kidneys began to fail. His lungs, damaged by smoke inhalation, filled with fluid. On the 15th day, we found more biological contamination in his wounds, even though we had been monitoring constantly. On the 17th day, his heart simply stopped. I was there when it happened. His monitor showed his heart rate dropping, and then went to 0. We attempted resuscitation, but honestly, it felt like we were disturbing the first peace he had known in over 2 weeks. The doctor stopped after 20 minutes, as I helped prepare Michael's body for transfer. I noticed that his body had already begun breaking down in places where the infection had been most severe. Parts of him were deteriorating while he was still technically alive those last few days. I went home that night, stood in the shower for an hour trying to process everything, and allowed myself to feel the full weight of what I had witnessed. That was my introduction to burn unit nursing. If you think that was difficult to hear, the challenges only intensify from here. My second story involves a woman named Rebecca, who came in after a kitchen accident. She had been cooking when her clothes caught fire from the gas stove. The burns covered about 60% of her body, mostly her torso, arms, and legs. But what made Rebecca's case particularly challenging was what happened during her recovery, or what should have been her recovery. Rebecca's burns were severe but survivable. We got her stabilized, started the careful process of daily wound care. And after 2 weeks, she was actually showing signs of improvement. The grafts we had done on her arms were taking well. Her spirits were relatively good, considering what she had been through. She would try to stay positive during dressing changes, even though we could see the tears streaming down her face from the discomfort. She was determined to get back to her 2 young daughters. But on day 16, something went wrong. I came in for my shift and immediately detected something different in Rebecca's room. It wasn't just the normal smell of burn wounds. This was worse, sweeter, more concerning. When I checked on her, she complained of feeling feverish and nauseous. Her temperature was elevated. We ran blood cultures and found a massive infection developing in her system. Within hours, Rebecca went from trying to stay positive to delirious with fever. The infection had gotten into her bloodstream, sepsis. But the truly alarming part came when we removed her dressings that evening. The skin grafts on her arms, which had looked healthy that morning, had turned dark. Completely dark. The infection had gotten underneath the grafts and was consuming the healthy tissue we had placed there. As we removed the compromised grafts, the odor that emerged made 2 of our team members have to leave the room immediately. The tissue underneath was breaking down. I'm not exaggerating, it was turning into a thick, dark liquid that seeped from the wounds. But what happened next elevated Rebecca's case from serious to critical. The infection was moving rapidly, spreading through her body faster than the antibiotics could work. By midnight, we could actually see it progressing up her arms. The skin would go from pink to red to purple to dark within hours. It was like watching the infection advance across her body in real time. The infection was necrotizing fasciitis, aggressive tissue destruction. The only way to stop it was to remove the infected tissue. All of it. The surgeon on call came in at 2 in the morning and examined Rebecca. What he said next was devastating. We need to take both arms. Now. If we don't, she won't survive until morning. Rebecca was barely conscious, but aware enough to understand what was being said. I held her hand, the hand that would no longer exist in a few hours. As the surgeon explained, they needed to amputate both arms at the shoulder. She just nodded weakly and whispered, "Save me. My babies need me." The emergency amputation was one of the most difficult procedures I've ever witnessed. Because of Rebecca's burn injuries, the surgery was complicated. When they made the first incision to begin the amputation of her right arm, the infection had spread so deep that fluid emerged from the wound under pressure. The odor was extremely strong, unlike anything I had experienced before. The surgeon worked quickly, cutting through tissue that was part healthy, part compromised. When they removed the first arm, I caught a glimpse of the cross-section. The muscle tissue showed dark lines of damage. The bone itself had started to darken. They repeated the process with the left arm. Through it all, Rebecca remained under anesthesia, mercifully unaware of what was being taken from her. When it was done, I helped wrap the surgical sites. She looked so small on that table, so fragile, with just her torso, head, and legs remaining. Rebecca survived the surgery. But when she woke up and realized what had happened, something broke in her spirit. She stopped speaking almost entirely. During dressing changes on her remaining burns and the amputation sites, she would just stare at the ceiling with empty eyes. The surgical sites required constant care to prevent more infection. The burn wounds on her legs continued to heal, but slowly. We brought in a psychiatrist, but Rebecca barely responded. She had lost not just her arms, but her will to continue. The most painful moment came 2 weeks after the amputation. Rebecca's mother had brought her 2 daughters to visit. They were 5 and 7 years old. When they saw their mother, arms gone, still covered in bandages from her burns, the younger one started crying and wouldn't come near her. The older daughter tried to be brave, but I could see the shock in her eyes. Rebecca watched this with no expression, but that night, I heard her sobbing. Not crying, sobbing, these deep sounds that seemed to come from somewhere beyond grief. She kept saying, over and over, "I can't even embrace them. I can't even hold my babies." Rebecca eventually left our unit and went to a rehabilitation facility. I heard later that she struggled significantly with the psychological impact of losing her arms. The physical wounds healed, but the emotional ones never did. The third case I want to tell you about involves a 19-year-old college student named Tyler. Tyler's story is different because it shows how burns can happen from things you'd never expect. Tyler wasn't in a fire. He was in a chemical accident in his university's lab. Someone had mislabeled containers, and Tyler grabbed what he thought was water to rinse something. It was actually concentrated sulfuric acid. The acid splashed onto his face, neck, chest, and hands. Chemical burns are different from thermal burns, and in many ways, they're more challenging. Fire burns the surface and goes deep, depending on exposure. But acid continues its damage, eating through layer after layer of tissue until it's neutralized. By the time Tyler got to us, the acid had been active for almost 20 minutes before they got it properly washed off. I'll never forget what his face looked like. The acid had eaten through his skin down to the muscle on his right cheek. I could see his teeth through the opening in his face. His right eye was completely clouded. The acid had destroyed his cornea. The tissue around his eye was severely damaged. His neck looked extremely compromised. Where the acid had contacted his chest, his skin had turned a sickly yellow-white color and had an unusual texture. His hands were the worst though. Tyler had instinctively tried to wipe the acid off his face with his hands, which meant both his face and his hands got full exposure. The skin on his palms had completely dissolved. I could see every tendon, every bone in his hands. Some of his fingers looked like exposed anatomy, just red muscle and white bone with no protective covering at all. The sounds of distress. The sounds were constant. Chemical burns hurt differently than regular burns. They keep causing discomfort because the damage continues at a cellular level even after the source is removed. Tyler was beyond conventional pain medication. We had him on everything we could legally give him, and he was still in extreme distress. Not words, just these continuous, high-pitched expressions of suffering that seemed to go on forever. The first dressing change was extremely difficult. We had to remove the dead tissue, which meant essentially clearing away the parts of his face and hands that had been destroyed. But with chemical burns, it's hard to tell where the compromised tissue ends and the viable tissue begins. Everything looked damaged. The doctor made the decision to be aggressive in removal, which meant we were going to take away tissue that might have still been viable to make sure we got all the damaged parts. When we started on his face, removing the necrotic tissue from his cheek, I realized we were essentially creating an opening through his face. The tissue came away in strips, revealing the inside of his mouth through his cheek. His teeth were fully visible from the outside. We had to pack the opening with sterile material to prevent infection, but that meant filling this space in his face. His hands were more challenging. As we removed tissue from his palms, the outer layers came off easily. Underneath, the muscles were gray and dying. We had to make a decision, try to save the hands or amputate. The problem was that the acid had damaged the bones themselves. When the doctor examined Tyler's index finger bone with a probe, it crumbled, just fell apart into fragments. The acid had penetrated into the bone. We ended up taking all the fingers on his right hand and 3 fingers on his left, leaving him with just his left thumb and pinky. But even that wasn't the end of Tyler's challenges. Over the next few days, the damage continued to spread. Chemical burns do that. They keep destroying tissue even after the initial injury. The acid had gotten into Tyler's system, and his kidneys started to fail. His lungs began filling with fluid. On day 5, we discovered that the acid had damaged his esophagus. He couldn't eat without severe discomfort, and we saw blood in his saliva. The most critical moment came on day 7. Tyler had been relatively stable, considering everything. But I came in for my shift and found him in severe respiratory distress. The acid damage to his throat and airway had caused swelling that was restricting his breathing. We had to do an emergency tracheotomy right there in his burn unit room. I assisted while the doctor created an opening in his throat to insert a breathing tube. Tyler's eyes were wide with fear, tears streaming down what remained of his face. The procedure saved his life, but now he had another wound to care for, another source of discomfort. Tyler survived, but the cost was enormous. He lost most of his fingers, his right eye, and a significant portion of his face. He needed multiple reconstructive surgeries. The psychological impact was immense. He had been a pre-med student, planning to become a doctor. After his accident, he dropped out of school. Last I heard, he was living with his parents, struggling with depression and trauma so severe he couldn't leave the house.
Story number 4 involves an elderly patient named Margaret, and it shows how age makes burn injuries exponentially worse. Margaret was 78 years old when she came to us. She had fallen asleep while smoking in bed, a classic but tragic accident. When her mattress caught fire, she was too disoriented and mobility impaired to escape quickly. Her back, buttocks, and the backs of her legs were severely burned, about 50% of her body. For a young person, 50% burns are survivable with proper care. For a 78-year-old with diabetes, high blood pressure, and osteoporosis, the survival rate drops dramatically. But Margaret was a fighter. She had survived difficult times in her life, raised 5 children alone after her husband passed away young, and wasn't about to give up without trying. That's what she told us anyway on her first lucid day. The problem with elderly burn patients is that their skin is already fragile. Their healing capacity is diminished, and they often have multiple other health issues complicating treatment. Margaret's case exemplified all of these problems. Her skin was so thin that during our first dressing change it tore in areas that weren't even burned. The healthy skin around her wounds would just separate if we weren't incredibly careful. And the burns themselves? They were deep. 3rd-degree burns across her entire back. When we cleaned the wounds for the first time, I could see her spine. Not just the outline through tissue. I could see the individual vertebrae bone exposed to the air. The muscles along her back had been damaged so thoroughly that they had the consistency of overcooked protein. In some places, they just separated when we removed the compromised tissue. Margaret was conscious during these early dressing changes, and she was stoic. She would grip the bed rails and stay silent, rarely crying out. She told me once, "I've been through worse. This is nothing." But it wasn't nothing. On day 4, we started noticing that Margaret's wounds weren't behaving like typical burn wounds. The edges weren't showing any signs of healing. In fact, they seemed to be expanding. The burns were spreading to areas that hadn't been initially damaged. At first, we thought it was infection, but cultures came back negative. What we eventually realized was happening was much worse. The combination of her age, her diabetes, and the trauma of the burns had caused her body's healing mechanisms to essentially shut down. Her body was giving up. The tissue around the burns was dying from lack of blood flow. We were watching this elderly woman's tissue deteriorate from the outside in. The odor became extremely strong. Even with daily cleaning and antibiotics, the compromised tissue produced a smell that was overwhelming. It was sweet and concerning, and made you want to leave even through your protective mask. On day 8, something happened that I still think about. I went in to do Margaret's morning wound check, and when I removed the bandage from her lower back, a large section of skin came away with the bandage. Not just the burned skin, all of it. What was left was exposed muscle and fat tissue. Margaret felt it happen. She made this sound, not loud, just this low expression of despair. "It's not healing, is it?" she asked me. I wanted to give her hope, but the look in her eyes told me she already knew the truth. "We're doing everything we can," I said, which was accurate but also not really an answer. The reality was that Margaret's body had given up even if her mind hadn't. Over the next week, I watched this proud, strong woman slowly decline. The wounds got larger. We could see more bone structure. Her pelvis became visible. The smell intensified, and then we discovered biological contamination. Despite our best efforts to keep the wounds sterile, somehow organisms had gotten to Margaret. We found them, numerous, in the dead tissue of her legs and buttocks. Normally, this can actually help by consuming dead tissue, but in Margaret's case, there was so much compromised tissue that they were thriving. I spent an hour with medical instruments removing them from this woman's body while she lay there silently crying. She didn't want her children to see her like this, she told me. She had forbidden them from visiting. "I want them to remember me how I was," she said. On day 19, Margaret developed sepsis. The infection from her deteriorating tissue had gotten into her bloodstream. She became delirious, talking to people who weren't there, reliving memories from decades ago. Her organs began to shut down one by one. Kidneys, then liver, then heart. We made her comfortable with strong medication, and she passed quietly in the early morning of day 21. When we prepared her body for her family, we had to use multiple layers of sheets because the wounds were still seeping and the odor was so persistent. I attended her funeral. Her children had no idea what their mother had endured in those final 3 weeks. Sometimes I think that's for the best.
The fifth story involves a case that affected our entire staff. Not just because of the injuries, but because of the victim's age. I won't give his real name, but I'll call him David. David was 11 years old when he came to our burn unit. He had been playing with friends when someone found a discarded container with flammable liquid. The boys didn't know what it was, but they knew it had some kind of fluid inside. Being curious kids, they decided to see what would happen if they poured it out and lit it. The vapor ignited before David could step back, and in an instant, he was engulfed in flames. His friends tried to help, tried to smother the fire with their jackets, but by the time an adult arrived and extinguished the flames, David had severe burns over 70% of his body. 70%. On an 11-year-old child. His entire torso, arms, and face were severely damaged. When David arrived, I almost left right then. Seeing a child with these injuries is different from seeing an adult. There's something fundamentally wrong about it, something that your mind rejects. David's face was altered beyond recognition. The fire had severely compromised his features. His eyelids were destroyed. His nose was severely damaged. His ears were affected. His facial structure had been compromised, giving him an appearance that was difficult to look at. But worse, this was a child. His small body was wrapped in temporary dressings that were already saturated with fluid leaking from his wounds, and he was conscious. He was calling for his mother, in this broken voice that still had the pitch of a child. His mother was there, extremely distressed, unable to look at her son. The doctors had to sedate her. David's first night was extremely difficult. We kept him heavily sedated, but even through the medication, he would make sounds of distress. The burns were so extensive that we couldn't even properly position him in bed. Every position caused pressure on burned tissue. We ended up putting him on a special airbed that constantly shifted to try to distribute his weight. But it only helped marginally. The dressing changes with David were the most challenging experiences of my career. This child, who should have been in 6th grade, learning and playing with friends, was instead lying in a burn unit bed, experiencing extreme discomfort, while we performed necessary procedures to keep him alive. Because that's what it was: necessary medical intervention. When we removed his dressings, his skin came away in sections. The burns were so deep that in many places we could see his chest structure. His small chest had visible bone showing through damaged muscle. His arms looked severely affected, with tissue stripped away to reveal bone. We had to remove compromised tissue aggressively to prevent infection, which meant clearing away damaged parts of this child's body. David would cry out in distress, calling for his mother, asking us to stop. His mother couldn't bear to be in the room. His father tried to stay, tried to be strong, but after the first dressing change, he left the room, and I found him in the stairwell, crying uncontrollably. What made David's case even more challenging was his awareness. Adults can sometimes mentally distance themselves from the experience, but David was just a kid. He couldn't process what was happening to him. Between the dressing changes, when we had him on enough pain medication to give him some relief, he would ask questions that were heartbreaking. Am I going to look normal again? Will I be able to go back to school? Do my friends think I look scary now? How do you answer those questions honestly to an 11-year-old? I couldn't. I would tell him that the doctors were doing everything they could, that he was being very brave, that his friends were worried about him and wanted him to get better. But I knew the truth. David would never look the same again. He would need dozens of reconstructive surgeries. He would probably need specialized education. The psychological impact alone would require years of therapy. And yes, unfortunately, children could be unkind. His appearance would likely make normal social interaction difficult for the rest of his life. On day 12, we ran into complications. The burns on David's chest had gotten infected, despite our best efforts. The infection was spreading rapidly, and his small body couldn't fight it off. His fever spiked to dangerous levels. He became delirious, experiencing hallucinations, calling out for his mother constantly. We maximized his antibiotics, but the infection had taken hold in the compromised tissue. The only option was aggressive surgical intervention, removing large portions of his chest tissue. The surgery took 6 hours. When they were done, David's chest was essentially an open wound. We could see his lungs moving underneath the thin layer of remaining tissue, protecting that wound, keeping it sterile, preventing further infection. It was nearly impossible. We did our best, we really did. But on day 17, David crashed. His small heart, damaged by the infection and the trauma, went into cardiac arrest. We performed resuscitation on this small boy. We got him back twice. But the third time, the doctor stopped. David was pronounced gone at 3:47 a.m. I had to clean his body, prepare him for his parents to see. I covered the worst of the wounds as best I could, but there was only so much I could hide. When David's mother saw her son, she collapsed, just completely collapsed, making sounds that didn't seem human. That sound stayed with me for months. Still does. I left the burn unit 3 weeks after David passed. I couldn't do it anymore. I transferred to a different department. It took me 2 years and significant therapy before I felt like I could function normally again. The 6th story involves a case of burns that started manageable but became a disaster due to complications. A 52-year-old construction worker named James came in with burns covering about 30% of his body, his arms and parts of his chest. He had been working with hot tar when a container spilled onto him. Tar burns are particularly challenging because the tar adheres to the skin and continues causing damage. It has to be carefully removed, which is extremely uncomfortable. But 30% burns are usually survivable, and James was healthy, so we were optimistic that optimism lasted exactly 5 days. On day 5, James started complaining of severe discomfort in his right arm, more than usual. When we removed the bandages, we saw why. The tissue underneath had turned very dark. Not the darkness of burned tissue, but the darkness of complete cell death. Necrosis had set in aggressively. The tar burns had been deeper than we initially thought, and the tissue death was spreading. We called in the vascular surgeon, who examined James's arm and delivered concerning news. The blood supply to the arm is compromised. We're going to lose it. The tar had effectively damaged the blood vessels in James's arm, and without blood flow, the tissue was dying. James was awake and aware when the surgeon told him they would need to amputate. "I'm a construction worker," James said. "I need both arms." The surgeon explained that, without the amputation, the dying tissue would become infected, the infection would spread, and James wouldn't survive. James just stared at his darkened arm and nodded. The amputation happened that evening. But here's where things got worse. During the surgery, they discovered that the necrosis had spread further up the arm than they'd thought. They had to take the arm at the shoulder rather than below the elbow like they'd planned. When James woke up from surgery, he looked down and saw that his entire arm was gone. Gone. He didn't speak for hours. Just stared at the bandaged surgical site. We tried to keep his spirits up, tried to talk to him about prosthetics and physical therapy, but he wasn't hearing it. His whole identity was tied up in his physical strength, his ability to work with his hands. Now he had one arm and extensive burns on the other. His career was finished. His sense of self was destroyed. But the challenges continued. 3 days after the amputation, the surgical site became infected. We had been careful, had done everything right, but sometimes infections just happen. The site began producing fluid. The stitches started to separate, and the odor was concerning. We had to open up the wound, clean it thoroughly, and essentially let it heal from the inside out. This meant James had a significant opening in his shoulder that we had to pack with sterile material every day and slowly allow to close. The discomfort was extraordinary. James began refusing pain medication, saying he wanted to feel everything, that he deserved to suffer. That's when we knew he was in serious psychological difficulty. The psychiatrist tried to work with him, but James was spiraling into deep depression. He stopped eating. He stopped speaking. When his wife and children came to visit, he wouldn't look at them. He would just lie there, staring at the ceiling, tears running down his face. One night, another nurse found James trying to remove his 4 lines. He was trying to harm himself, trying to cause a fatal complication. We had to put him on a psychiatric hold, post security outside his door continuously. He was listed as a self-harm risk. The wound in James's shoulder eventually healed, but slowly. It took 6 weeks for that opening to close. 6 weeks of daily packing and cleaning. 6 weeks of James lying in a hospital bed, getting thinner and more withdrawn. The burns on his remaining arm healed too, but left thick scars that limited his range of motion. When James was finally discharged, he wasn't going home. He was being transferred to a psychiatric facility. His wife told me privately that she didn't know if their marriage would survive this. James had changed, she said. He wasn't the man she married anymore. I don't know what happened to James after that. I hope he found a way to cope, to rebuild his life. But I've seen enough to know that some people never recover from that level of trauma. The physical wounds heal eventually, but the psychological wounds, those can last forever. Story 7 involves a case that still affects me because of how unexpected it was. A 25-year-old woman named Amanda came to us with burns on her legs and lower back. She had been in a car accident where her vehicle caught fire. She managed to escape, but not before sustaining significant burns. About 40% of her body. The burns were severe, but Amanda was young and healthy. We expected a difficult recovery, but a recovery nonetheless. Amanda was actually in good spirits initially. She maintained positivity, interacted warmly with the staff, talked about her plans for after she healed. She was getting married in 6 months, she told us, and nothing was going to stop that. Her fiancé visited every day. They would hold hands, carefully, because of her injuries, and talk about their future. It was one of the few positive aspects in the burn unit, seeing their love and optimism. That lasted until day 9. On day 9, I came in for my shift, and something was wrong. Amanda's room had an unusual odor, and when I checked on her, she was lethargic and unresponsive. Her temperature was elevated significantly. Her blood pressure was dropping. When we removed her dressings, we found the source. The burns on her thighs had become massively infected, and the infection had spread to the deeper tissues. We're talking about necrotizing fasciitis. Again, aggressive tissue destruction. The tissue of her thighs was literally breaking down. When I examined the area with a gloved hand to assess the damage, my finger sank into her leg like it was soft material. The infection had consumed the muscle and was rapidly spreading. We called the surgeon immediately. Amanda was semi-conscious during the examination, and I heard the surgeon say to his resident, "We're going to have to take both legs. There's no other option." Amanda heard this too. Her eyes went wide, and she tried to sit up, tried to speak, but she was too weak. Her fiancé was in the waiting room. I had to go tell him that his future wife was about to lose both her legs. The emergency surgery lasted 9 hours. They took Amanda's legs, mid-thigh, bilateral amputation. When she woke up and realized what had happened, her cries echoed through the entire unit. Not expressions of pain, expressions of anguish, of loss, of a future destroyed. Her fiancé came in to see her, and Amanda begged him to leave. "I'm not the woman you proposed to," she said through tears. "I'm different now. You need to leave and forget about me." He tried to reassure her, tried to tell her that he loved her no matter what, but Amanda was inconsolable. She told him to leave until staff had to escort him from the room. Over the next week, Amanda refused to see him. She refused to see anyone. She lay in her bed, staring at where her legs used to be under the sheets, not speaking, barely eating. The surgical sites required constant care. They were still dealing with infection, still at risk of the destruction spreading further. Every dressing change, Amanda would just lie there silently, tears streaming down her face, not even reacting to the discomfort. What happened next is something I think about often. Amanda's fiancé kept coming to the hospital every day, even though she refused to see him. He would sit in the waiting room, just sit there for hours, hoping she would change her mind. On day 18, Amanda finally agreed to see him. I wheeled her out to the family room. She still couldn't use a regular wheelchair comfortably because of her surgical sites. Her fiancé took one look at her and started crying. Not loud, just tears running down his face. He knelt down next to her wheelchair and took her hand. "I don't care about your legs," he said. "I care about you. I love you. That hasn't changed. That will never change." Amanda broke down. They held each other and cried for a long time. I left them alone. A month later, Amanda was discharged to a rehabilitation facility. 6 months after that, I received a wedding invitation. Amanda and her fiancé got married. The invitation included a note. "Thank you for saving my life and teaching me that life is worth living, no matter what form it takes." I attended the wedding. Amanda was in a wheelchair, but she was smiling. It was one of the few positive outcomes I've witnessed in the burn unit. The 8th case involves an electrical burn, which are some of the most deceptive and dangerous burns we see. A 31-year-old electrician named Robert came in after being electrocuted on a job site. He had been working on high-voltage lines when something went wrong and 60,000 volts went through his body. Electrical burns are unusual because often the skin looks relatively okay on the surface. But underneath, the electricity has damaged everything. It follows the path of least resistance through the body, usually through blood vessels and nerves, destroying everything internal while leaving the surface relatively intact. Robert came in conscious and talking. On the surface, he had burns on both hands where the electricity entered and exited, but they didn't look that severe. "We've all seen worse," we thought. That assessment was completely wrong. Within hours, Robert's condition deteriorated. His kidneys started shutting down. His heart rhythm became irregular. And then we discovered the full extent of the internal damage. When we did imaging, we found that the electricity had essentially damaged Robert's arms from the inside. The muscles were dead. The blood vessels were destroyed. The nerves were compromised. On the outside, his arms looked relatively normal. Some redness, some blistering, but nothing terrible. But inside, everything was destroyed. The doctor explained it to Robert's wife like this. "Imagine food that's been overheated internally. It looks okay on the outside, but inside, it's completely damaged. That's what happened to your husband's arms." Within 24 hours, the dead tissue inside Robert's arms started to break down and release toxins into his bloodstream. This caused a serious condition where damaged muscle tissue breaks down and releases proteins into the blood that can damage the heart and kidneys. Robert's kidneys were failing. His blood was becoming toxic. The only solution was to amputate both arms before the toxins ended his life. But even that wasn't straightforward. Because the damage was internal, the surgeons couldn't just cut at the point where the burns looked worst. They had to cut high up on the arms, almost at the shoulders, to make sure they were getting above all the dead tissue. Robert went from being a healthy man with what looked like minor burns to a double amputee in less than 48 hours. The speed of it was shocking. His wife was in complete denial. "But his arms looked fine yesterday," she kept saying. "How is this possible?" We tried to explain about electrical burns, about internal damage, but she couldn't process it. Neither could Robert. When he woke up from the amputation surgery and saw that both his arms were gone, he became physically ill. Just turned his head from the shock and horror. I had to help clean him, had to help him come to terms with the fact that he would never use his hands again, never embrace his wife properly, never hold his newborn daughter who was due in 2 months. That last part destroyed him. "I'll never be able to hold my baby," he said. "What kind of father can't hold his own child?" We tried to tell him about prosthetics, about adaptive devices, about other amputees who had lived full lives. He didn't want to hear it. The surgical sites on Robert's shoulders developed complications. The surgeons had tried to preserve as much as possible, which meant they cut close to damaged tissue. Infections set in, the wounds wouldn't heal properly. Robert needed multiple revision surgeries, each time removing more tissue. With each surgery, he became more withdrawn, more depressed. He stopped talking to his wife. He stopped asking about the baby. He just lay there in bed, staring at nothing. I tried to connect with him, tried to get him to open up, but he had shut down completely. One night, I found him trying to harm himself with his pillow. He couldn't do it effectively without hands to assist, but he was trying. We had to put him on close observation too. Eventually, Robert was stable enough to transfer to a psychiatric rehabilitation facility. His baby was born while he was still in our unit. His wife brought pictures, but Robert wouldn't look at them. The last time I saw Robert was the day he was transferred. He looked like someone who was physically present. Story number 9 involves something I never thought I'd see. A case where we had to essentially rebuild someone's face from scratch. A 45-year-old man named Vincent came to us after a propane explosion at his home. He had been grilling when the tank malfunctioned and exploded directly in his face. The blast and fire destroyed his entire face. And I mean destroyed. When Vincent arrived, his face was unrecognizable as human. It looked like raw tissue. His nose was completely gone, not burned, but blown off. His eyes were severely damaged, possibly permanently. His jaw was broken in multiple places. The skin of his face had been partially removed by the blast, and what remained was severely burned. The burns extended down his neck and onto his chest, but the worst damage was definitely the face. The emergency doctor who brought him up to us warned us it was severe, but nothing could have prepared us for the reality. Vincent was sedated and intubated. It was impossible to tell what he had looked like before. We couldn't even determine basic features. His face was just a mass of destroyed tissue. The first priority was keeping Vincent alive and preventing infection. With facial burns this severe, the risk of infection is enormous because there's so much exposed tissue. We kept him sedated for the first week while we did initial tissue removal and grafting. The process of cleaning his facial wounds was unlike anything else. We had to remove pieces of his skull that had been damaged by the blast. We had to extract embedded debris, pieces of the propane tank, bits of his grill, even fragments of his own teeth that had been blown into the soft tissue of his cheeks. When the surgeons did the first major reconstruction, they had to essentially build a new face. They used skin grafts from his thighs to cover the raw tissue. They constructed a new nose using cartilage from his ribs. They rebuilt his eye sockets and jaw. The surgery took 14 hours. When it was done, Vincent had a face again, but it didn't look natural. It looked like a reconstruction, smooth and somewhat featureless, with grafted skin in different tones patched together. The new nose was a small projection without proper structure. His eyes were covered with grafts. We still didn't know if he would ever see again. When Vincent finally woke up and was conscious enough to understand what had happened, we made the mistake of giving him a mirror. He had been asking to see his face, insisting that he needed to know. We should have waited, should have prepared him better. The moment Vincent saw his reflection, he made a sound I've never heard before or since. It wasn't typical crying. It was this expression of pure despair. He looked at his reconstructed face, at the place where his nose should be, at his covered eyes, and something broke in him. He started trying to damage his face, trying to tear off the grafts. "I'm changed," he said loudly. "I'm completely different." It took several of us to restrain him and sedate him. After that, we removed all mirrors from his room and put him on heavy psychiatric medications. Vincent's recovery was long and painful. He needed multiple additional surgeries to refine his reconstruction. They were able to open his eyes eventually. He had limited vision in one eye, was completely blind in the other. They created openings in his reconstructed nose. They fixed his jaw enough that he could eat soft foods. But no matter how much work they did, Vincent would never look the same again. The psychological impact on Vincent was profound. He refused to see his family for months. His wife and children begged to visit, but Vincent wouldn't allow it. "I don't want them to see me like this," he said. "I don't want them to remember me this way." Eventually, the psychiatric team and his family convinced him to allow a visit. I was there when his wife and 2 teenage children came in. The kids saw their father's reconstructed face and tried to hide their reactions, but I could see the shock in their eyes. His wife broke down crying. She tried to embrace Vincent, but he pulled away. "Don't touch me," he said. "I know how I look." His daughter, who was 16, started crying and ran from the room. His son, 14, tried to be brave, but you could see him struggling not to stare at his father's face. The visit lasted less than 10 minutes before Vincent asked them all to leave. After they left, Vincent was silent for hours. That night, he told his nurse that he wished he had not survived the explosion. "It would have been better for everyone," he said. Vincent was eventually discharged after 4 months in our unit. He went home, but from what I heard from his wife during follow-up, he never left the house. He wore a prosthetic nose and covering in public, but even with those, his appearance was notable. Children would stare. Adults would look away quickly. Vincent became isolated, barely leaving his bedroom. His family tried to be supportive, but the strain destroyed their relationships. His wife told me, a year later, that they were divorcing, not because she didn't love him, she said, but because Vincent had pushed everyone away so completely that there was nothing left of their marriage. Vincent's case taught me that sometimes the worst burns aren't the ones that end your life. Sometimes they're the ones that leave you alive but completely destroy your quality of life. The 10th story is about a case that still makes me question if we did the right thing. A 71-year-old man named Harold came to us with severe burns from a house fire. He had been asleep when the fire started, and by the time firefighters got him out, he had third-degree burns over 80% of his body. At 71, with burns that extensive, survival is almost impossible. But Harold's family insisted we do everything possible to save him. Harold was unconscious for the first 3 days. When he woke up, he was in severe discomfort, despite maximum pain medication. His entire body was essentially one giant wound. We couldn't even properly turn him in bed, because there was nowhere to touch that wasn't burned. The odor in his room was overwhelming: burned tissue, infection, deterioration, all mixed together. Harold's first words when he woke up were, "Let me go." He said it clearly, despite his damaged throat and lungs. "Please," he said weakly, "let me go." But his family wouldn't hear it. His daughter insisted we continue treatment. "My father is a fighter," she said. "He would want to live." But that's not what Harold was telling us. Every time he was conscious, he begged us to stop treatment. "I'm suffering," he would say. "Please, I'm begging you, let me go." The ethical dilemma was enormous. Legally, Harold was competent to make his own medical decisions. But his daughter had medical power of attorney and was overriding his wishes. The doctor tried to explain to her that her father's chances of survival were less than 5%. And even if he survived, his quality of life would be terrible. He would never walk again, never be independent, would need continuous care, would be in constant discomfort. She didn't care. Do everything, she insisted. So we did. And it was extremely difficult. Every dressing change, Harold would cry out and beg us to stop. "Just let me go," he would say. "Please, I can't take this anymore." But we kept treating him, because that's what his daughter wanted. Harold's body began to fail. His kidneys shut down. He developed infections in multiple sites. His wounds wouldn't heal. His body was too old, too damaged. But we kept him alive with dialysis, antibiotics, medications to support his blood pressure. We were using machines and medicines to force a body that wanted to stop to keep going. On day 23, Harold developed septic shock. His blood pressure dropped severely. His organs were failing. The doctor sat down with Harold's daughter and explained that this was it. Without aggressive intervention, Harold would pass within hours. With aggressive intervention, he might survive a few more days or weeks, but would likely never wake up again. "Do everything," she said again. So we did. We intubated Harold, put him on a ventilator, maximized his support medications. He was essentially being kept alive by machines at that point. He was sedated, unconscious, his body swollen and seeping from dozens of wounds. 3 days later, his heart finally stopped. We performed resuscitation, performing compressions on his damaged chest. We got him back twice, but the third time, after 30 minutes, the doctor finally stopped. Harold was gone. At the family meeting after Harold's passing, his daughter thanked us for doing everything we could. She said her father would have been grateful. I wanted to tell her the truth. "Your father wasn't grateful. Your father begged us to let him go. Your father spent the last 3 weeks of his life in suffering because you couldn't accept his wishes." But I didn't say anything. I just nodded and offered my condolences. That night, I went home and allowed myself to feel the full weight of what had happened. Not for Harold's passing, that was actually a relief for him, but for the fact that we had gone against this man's wishes for 3 weeks to make his daughter feel better. I seriously considered leaving nursing after Harold's case. I felt like we had violated everything medicine should be about. We had done harm, not good. Eventually, I stayed, but Harold's case changed me. Now, when family members insist on aggressive treatment against a patient's wishes, I advocate more strongly for the patient. Sometimes, the most compassionate thing we can do is respect someone's wishes to stop. The 11th story involves a unique case that showed me how burns can come from sources you'd never expect. A 34-year-old woman named Lisa came to us with chemical burns from a beauty treatment gone wrong. She had been getting a chemical peel at a medical spa when something went horribly wrong with the solution they used. The esthetician had mixed the chemicals incorrectly, creating a much stronger solution than intended. When they applied it to Lisa's face, it immediately started causing damage. By the time they realized what was happening and washed it off, severe harm had been done. Lisa's face, neck, and upper chest had 2nd and 3rd degree chemical burns. The worst part was that because it was a facial treatment, the chemicals had been applied evenly across her entire face. Both eyes were affected. Her whole face was burned uniformly. When Lisa arrived, her face was bright red and already blistering. Within hours, the blisters broke and the skin began to peel away in sections. Unlike thermal burns, chemical burns continue to damage tissue even after the source is removed. The chemicals had soaked into Lisa's skin and were still causing destruction at a cellular level. The first few days were critical. We had to aggressively wash Lisa's face and upper body to neutralize any remaining chemicals, which was extremely uncomfortable for her. The skin of her face was so sensitive that even the gentlest water pressure caused severe discomfort. Lisa would cry out during these washing sessions. "I just wanted to look better," she would say. "I just wanted to reduce some aging signs." The irony was heartbreaking. Lisa had gone in for an aesthetic treatment and come out with severe injuries. As the days progressed, Lisa's face went through concerning changes. The burned skin turned dark and started to die. We had to remove tissue from her face, essentially clearing away the dead skin to prevent infection. But underneath the dead skin wasn't healthy skin, it was raw, damaged tissue. Lisa's face looked severely compromised. Her eyelids had been so badly burned that they couldn't close properly. Her eyes were constantly exposed, at risk of drying out and being damaged further. We had to put special ointments on her eyes every hour continuously. Her lips had partially fused from the burns and had to be carefully separated, which was extremely uncomfortable. What made Lisa's case particularly challenging was that she was a model. Her face was her livelihood. She had campaigns lined up, a successful social media following, contracts with major brands. All of that was destroyed in the 30 minutes she spent getting that chemical peel. The psychological impact was immense. Lisa refused to look at herself in any reflective surface. When we had to show her her face to explain the treatment plan, she had a complete breakdown. She looked at her damaged face, red, raw, weeping, nothing like the beautiful woman she had been just days before, and started having difficulty breathing. "My life is over," she said. "Everything I am is gone." We had to sedate her. Over the following weeks, we did multiple skin grafts on Lisa's face. We took skin from her thighs and carefully placed it on her face, trying to create as natural an appearance as possible. But facial grafts are challenging. The skin from other parts of the body doesn't match facial skin in texture or color. When the grafts healed, Lisa's face was a patchwork of different skin tones and textures. It looked better than raw tissue, but it definitely didn't look the same. Lisa underwent her first major reconstructive surgery 6 weeks after her initial injury. The surgeons did their best to even out the skin tones, smooth the texture, recreate some of her features that had been lost. When Lisa finally saw the result, she burst into tears. It was better, definitely better than it had been. But it wasn't her face. The woman in the mirror was different. The skin grafts had a slightly different texture. The color wasn't quite right. Some areas were still obviously scarred. "I'm never going to work again," Lisa said. "Who's going to hire a model who looks like this?" She was right, unfortunately. Her modeling career was finished. Her social media followers dropped by the thousands once she posted about her injury. The brands canceled their contracts. The medical spa that had done the procedure declared bankruptcy and closed rather than face Lisa's lawsuit. Lisa was left with massive medical bills, no income, and a face that would never be the same. The last I heard, Lisa had moved away, changed her name, and was trying to start over somewhere where no one knew her or what had happened. Her case made me realize that burns don't just destroy bodies. They destroy lives, identities, futures. The 12th case is another pediatric case, and it involves something that still makes me angry to this day. A 6-year-old girl named Emma came to us with burns covering 40% of her body. Emma had been at a backyard cookout when adults were being careless with lighter fluid. Someone squirted lighter fluid onto an already lit grill to make bigger flames, and the fire flashed back along the stream of fluid, to the container. The container exploded, spraying burning fluid everywhere. Emma, who had been standing nearby watching the adults cook, was doused in burning fluid. The adults panicked. Instead of properly responding, they reacted poorly while this child burned. By the time someone grabbed a hose and extinguished the flames, Emma had been on fire for almost 2 full minutes. The burns covered her legs, arms, and part of her torso. They were deep, third-degree burns in many places. When Emma arrived, she was in shock. Her eyes were wide. She wasn't crying, just making these little sounds of distress. Her small body was covered in darkened, charred skin. Parts of her were still producing smoke. Treating a 6-year-old burn victim is heartbreaking in ways I can't fully express. Emma didn't understand what had happened to her. She didn't understand why she was experiencing such discomfort. She kept calling for her mommy, who was in the waiting room being treated for minor burns herself. She had finally been the one to extinguish Emma with the hose. Emma's first dressing change was one of the hardest things I've ever had to do professionally. This little girl, who should have been in 1st grade learning to read, was lying on a burn unit bed while we removed her destroyed tissue. She cried out and moved around. It took 3 of us to gently restrain her while we worked. We had her on pain medication, but there's only so much you can give a small child. "I want my mommy," she cried. "I want to go home." We couldn't bring her mother in during the dressing changes. It was too difficult for a parent to watch. So Emma experienced this alone, surrounded by masked strangers who were causing her discomfort even though we were trying to help. Emma's legs were the most severely affected. The burns there had penetrated deep into the muscle. We could see bone in places. The decision was made to amputate Emma's left leg below the knee. The burns there were so severe that the leg wouldn't function even if we preserved it, and keeping it would increase infection risk and prolong her suffering. How do you tell a 6-year-old that you're going to remove her leg? The child psychologist tried to explain it in age-appropriate terms, but Emma didn't understand. She just knew that something else difficult was going to happen to her. When Emma woke up from the amputation and realized her leg was gone, she was confused more than anything. "Where's my leg?" she kept asking. "When will it grow back?" We had to explain to a 1st grader that her leg wouldn't grow back, that it was gone permanently, that she would need a prosthetic. Emma's mother was devastated. She blamed herself for letting Emma be near the grill. She blamed the adults who had been careless with the lighter fluid. She blamed everyone. Emma had to stay in the burn unit for 6 weeks. 6 weeks of uncomfortable dressing changes, of skin grafts, of learning to cope with her amputated leg. 6 weeks of this little girl crying herself to sleep every night. What really affected me about Emma's case was watching her lose her innocence. When she first arrived, despite the discomfort, there was still a spark of childhood in her eyes. She would sometimes smile when we brought her a stuffed animal or played a video for her. But, as the weeks wore on and the procedures continued, that spark faded. Emma became withdrawn. She stopped smiling. She stopped engaging with us. This 6-year-old child was developing trauma right before our eyes. She would have nightmares about fire. She would become anxious whenever she saw someone in medical clothing approaching. She reacted negatively to every touch. By the time Emma was discharged, she was a different child from the one who had arrived. She would need years of physical therapy for her burns and her amputation. She would need years of psychological therapy for her trauma. Her childhood was effectively changed at age 6 because adults were careless at a backyard cookout. I still think about Emma sometimes and hope she's okay. Hope she found some way to heal, not just physically but emotionally. But I know that's probably difficult. Some wounds never fully heal. The 13th story involves a case of burns from a source most people never think about: steam. A 40-year-old chef named Marcus came to us after a serious steam burn at his restaurant. A pressure cooker had malfunctioned and exploded, releasing superheated steam directly into Marcus's face and chest. Steam burns are deceptive. People don't think steam can be that dangerous. But superheated steam can be over 300 degrees Fahrenheit, and it penetrates deeply into tissue. When Marcus arrived, his face and chest were bright red and already blistering extensively. But the real damage was underneath. Steam doesn't just burn the surface, it penetrates into the airways, into the lungs. Marcus was having severe respiratory distress. We had to intubate him immediately because his airway was swelling from the internal burns. The steam had damaged the inside of his throat, his trachea, his lungs. While his face looked concerning, what we couldn't see was even worse. Over the first 24 hours, Marcus's condition deteriorated rapidly. The burns to his lungs caused massive inflammation and fluid buildup. He developed acute respiratory distress syndrome. His lungs were failing. We had him on a ventilator at maximum settings, but his blood oxygen levels kept dropping. The lung specialist explained to Marcus's wife that the steam had essentially damaged the delicate lung tissue, causing severe harm. Even if Marcus survived, he would likely never breathe normally again. His face was also worsening. The initial red burns had progressed to deep second and third-degree burns as the heat damage became apparent. His forehead, nose, cheeks, and chin were covered in large blisters that broke and leaked fluid. The skin underneath was raw and red. When we did the first tissue removal from his face, the skin came off in large sections, revealing raw tissue underneath. Marcus remained sedated and intubated, which was fortunate. If he had been awake, the discomfort would have been unbearable. His wife visited every day, standing by his bedside, talking to him even though he couldn't respond. She would tell him about their restaurant, about their 2 kids, about how everyone was waiting for him to come home. It was heartbreaking because we knew the truth: Marcus probably wasn't going home. On day 8, Marcus developed pneumonia on top of his burn injuries. His damaged lungs couldn't clear secretions properly, creating a perfect environment for bacteria. Despite powerful antibiotics, the infection spread rapidly. His fever increased, his blood pressure dropped. He was going into septic shock. We maximized his medications, but his body was shutting down. The doctor sat with Marcus's wife and explained that there was nothing more we could do. Marcus's lungs were too damaged. The infection was too widespread. They could continue aggressive treatment, but Marcus would never wake up, would never breathe on his own, would never be the husband and father he had been. His wife made the hardest decision of her life. She agreed to withdraw life support. I was there when they extubated Marcus. His wife held his hand, tears streaming down her face, telling him it was okay to let go. Without the ventilator, Marcus's damaged lungs couldn't sustain him. He passed within 20 minutes. His wife kissed his forehead, one of the few parts of his face that wasn't severely burned, and whispered, "I love you. I'm so sorry." Marcus's case stays with me because it seemed so preventable. If the pressure cooker had been maintained properly, if safety protocols had been followed, he would still be alive. His kids would still have their father. His wife would still have her husband. But instead, a mechanical failure and a moment of bad timing led to this outcome. I think about all the times I've used a pressure cooker at home and never thought twice about the danger. Now I never use one without thinking of Marcus. Without remembering his burned face and failing lungs, without remembering his wife's grief. Burns can come from anywhere, from anything. Fire, chemicals, electricity, steam. There are so many ways to be burned, so many ways to suffer. The 14th case involves a 28-year-old man named Derek, who came to us with burns that were self-inflicted, but not in the way you might think. Derek was a recovering substance user who had relapsed and passed out while using. He had fallen asleep on his bed, with lit materials still active. The mattress caught fire, and Derek, under the influence and unconscious, didn't wake up until the fire was already extensive. By the time neighbors broke down his door and dragged him out, Derek had burns over 60% of his body. But Derek's case was complicated by the fact that he was actively under the influence when he arrived. The substances in his system made him paranoid, aggressive, and impossible to treat initially. He fought against the nurses, pulled out 4 lines, said we were trying to harm him. It took security and medication to calm him down enough to treat him. When Derek finally came down from the high and realized the extent of his injuries, his reaction was unexpected. "I deserve this," he said without emotion. "This is what I get." He told me that the burns were punishment for his relapse, for his addiction, for his life choices. He refused pain medication beyond the bare minimum, saying he needed to feel the discomfort to remember why he had to stay clean. Derek's burns were extensive and severe. His back, legs, and arms were covered in third-degree burns. Large areas of tissue had to be removed and grafted. But what made Derek's case particularly challenging was his mental state. He was deeply depressed, saw his burns as deserved punishment, and actively undermined his own recovery. He would refuse to do physical therapy exercises. He would interfere with his grafts when no one was watching, causing damage. He would refuse to eat, saying he didn't deserve to get better. We had to involve psychiatry, but Derek wouldn't engage with them either. He had essentially given up. The discomfort of his burns seemed to be the only thing that made him feel present. That confirmed his belief that he deserved to suffer. One night, I found Derek crying in his bed. Not from physical discomfort, but from emotional pain. "I had 6 years clean," he told me. 6 years. And I threw it all away for one use. Now look at me. I'm damaged, inside and out. I tried to tell him that addiction was a disease, that relapses happen, that his burns didn't define him. He wasn't hearing it. Derek's road to recovery was long and painful. His burns were healing, but slowly. He developed infections multiple times because he wouldn't follow wound care instructions properly. He would deliberately not clean his wounds, saying it didn't matter. His grafts failed in several places and had to be redone. Through all of this, Derek remained in this state of self-punishment. It was heartbreaking to watch someone actively work against their own healing. About 2 months into his stay, something changed. Derek's sponsor from his recovery program came to visit. I don't know what they talked about, but after that visit, Derek seemed different. He started engaging with his treatment. He started doing his exercises. He started taking better care of his wounds. He even started talking to the psychiatrist. When I asked him what changed, he said, "My sponsor reminded me that recovery isn't just about staying clean. It's about healing from everything, including this." He said, "My burns weren't punishment, they were just another thing I had to overcome." Derek was eventually discharged to a rehabilitation facility that specialized in both burn recovery and substance use treatment. I saw Derek about a year later at a follow-up appointment. He was doing well. His burns had healed, leaving extensive scarring, but he was functional. More importantly, he was clean. He told me he had been sober for 10 months, that the burn injury had actually been a wake-up call. "I went through hell," he said. "Literally. There's nothing worth going through that again." He showed me his burned scars with a kind of pride. These remind me every day of what my lowest point looked like. They keep me honest. Derek's case taught me that sometimes the physical trauma of burns is secondary to the psychological struggles people are already carrying. And sometimes, recovery from burns and recovery from other issues have to happen together. The final story I want to share is actually the case that made me leave the burn unit permanently. It involves a very young patient I'll call Sarah. Sarah came to us after being accidentally exposed to scalding water. Her parent had been filling a tub, testing it carefully. When Sarah's older sibling accidentally bumped into the walker Sarah was in, Sarah rolled into the bathroom and tipped over into the tub of extremely hot water. By the time her parent pulled her out, just seconds really, Sarah had suffered burns over a significant portion of her small body. When Sarah arrived, her cries filled the entire unit. High-pitched, distressed cries that triggered every protective instinct you have. Her tiny body was red and blistering. Her delicate skin was peeling. We had to intubate her immediately because of the risk of airway swelling. Treating such a young burn patient is unlike anything else in medicine. Every procedure that's difficult on an adult is exponentially harder on a small child. Their skin is so delicate, their bodies so small, the margin for error so tiny. Sarah's parent was extremely distressed with guilt. It had been an accident, a terrible, tragic accident, but they blamed themselves completely. They would sit by Sarah's specialized bed. We couldn't use a regular bed for someone so small, and express grief for hours. Sarah remained sedated for the first week. When we had to do wound care, removing the damaged skin from her tiny body, it felt like we were causing harm. This child, who should have been reaching developmental milestones and experiencing normal infant activities, was instead lying in a burn unit being subjected to difficult procedures. We had to be extremely careful with pain medication because young children process drugs differently than adults. Too much could be dangerous. Too little, and they would suffer. Finding the right balance was nearly impossible. Sarah's burns required multiple skin grafts. We took skin from her tiny legs and placed it on her burned torso and arms. But infant grafts don't take as reliably as adult grafts. We had to redo several procedures when the first grafts failed. Each time, we had to harvest more of her precious healthy skin, creating more wounds, more discomfort. The psychological impact of watching such a young patient suffer like that affected our entire team. Nurses who had been in the burn unit for years were having emotional reactions in break rooms. The doctor handling Sarah's case looked like he aged significantly in 2 weeks. Sarah's parents stopped eating, stopped sleeping, just maintained a constant presence by their child's side. On day 12, Sarah developed a severe infection. Her tiny immune system couldn't fight off the bacteria that had gotten into her wounds. Her temperature increased. Her blood pressure dropped. We gave her powerful antibiotics, but her small body was shutting down. The pediatric specialist explained to Sarah's parents that their child's chances were very poor. Her organs were failing. Her burns were too extensive for her small body to heal from. They could continue aggressive treatment, or they could make Sarah comfortable and let her go peacefully. Sarah's parents chose comfort care. I was there when they removed Sarah's breathing tube and turned off the monitors. Her parent held her tiny burned body, extremely careful of the wounds, and rocked her gently. Sarah's other parent sang softly through tears. Sarah passed in her parents' arms. I requested a transfer the next day. I couldn't continue. Couldn't watch people suffer like that. Couldn't perform painful procedures in the name of healing. couldn't witness these outcomes. The burn unit had affected something in me, some essential optimism about humanity and healing. I had seen too much suffering, too much difficulty, too much loss. Some people can work in burn units for their entire careers. I admire them, but I'm not one of them. Sarah's case was my breaking point. I transferred to a different specialty and never looked back. But I carry the memories of my burn unit patients with me always. Michael, with biological contamination in his wounds. Rebecca, who lost her arms. Tyler, whose face was destroyed by acid. David, the 11-year-old who suffered and passed. Vincent, whose face was rebuilt but whose life was destroyed. Harold, who asked to be allowed to go but was kept alive. Emma, the 6-year-old who lost her leg and her innocence. Marcus, who passed from steam burns. And Sarah, who suffered beyond imagination. Their stories, their struggles, their experiences, they're burned into my memory forever. If you've watched this entire video, thank you. I know it was difficult to hear. These stories are difficult for me to tell, even years later. But they're important. People need to understand that burns aren't just injuries. They're life-altering traumas that affect not just the victims but their families, their caregivers, everyone around them. Burns destroy bodies and lives in ways that few other injuries can match. If you take anything away from these stories, let it be this. Be careful around fire, chemicals, electricity, steam, hot water. Respect the danger. Follow safety protocols. Don't be careless. Because in a split second, your life or someone else's life can change forever. If these stories affected you, please hit that like button and leave a comment below, sharing your thoughts. Subscribe to our channel and turn on notifications so you don't miss our next video, where I'll be sharing more stories from different areas of medicine that will show you another side of medical challenges. Thank you for watching, and stay safe out there.